All right. If you are still listening to these videos and are not annoyed with me yet, this will certainly push you over. In this video, we're going to talk about the myth that Enterococcus is a virulent urinary pathogen and always needs antibiotics. In this series of videos that I've been doing, I've been addressing training myths related to the urinary tract. However, at this point, I'm hoping that I've at least made the case that any bacteria in the urine is not necessarily a pathogen that needs to be treated. Symptoms should define need for antibiotic treatment, not altered mental status, not acute kidney injury, etc. So, could Enterococcus be a true uropathogen? Sure. Symptomatic patient, growing only Enterococcus, I would treat. But I hate Enterococcus. I'm not convinced it's hypervirulent like Staphylococcus aureus and even other streptococci. Sure, it can cause endocarditis, and I would never ignore it in the blood. But do I feel the same when I see it in fluid from the urine or even from abdominal fluid? Not really. I kind of feel like Enterococcus is the Coag Neg Staph of the urinary tract. Yes, it can cause symptoms. Yes, it may need antibiotics, but more often than not, it's a false alarm. We see it all the time because ceftriaxone is overused for everything. Pneumonia, urinary tract infection, peritonitis, you name it. Ceftriaxone doesn't cover Enterococcus, so it's always the one bug that you find in treatment-experienced patients, and usually is a false alarm as opposed to something that I would take super seriously. A lot of this is my personal bias. I just hate Enterococcus. It's annoying. But what does the evidence say? Well, Enterococcus really likes to be cultured out of the urine, but I note that many treatment algorithms do not include coverage of Enterococcus empirically. Again, it's usually found in patients who are treatment experienced, have recurrent disease, have neobladders, or other necessities for recurrent instrumentation. Despite the fact that it's very common to find, it's rare to cause upper tract disease like pyelonephritis. Like Coag Neg Staph, removal of the plastic is probably enough to eradicate the colonization in most cases. In a study looking at patients with Enterococcus in the urine, 50% were symptomatic, and of those, 70% had pyuria, which may be a helpful clue if Enterococcus is really causing problems. And you have unclear symptomatology. In that situation, like say bladder spasms, for instance, and the patient grew Enterococcus, I probably wouldn't treat if there weren't pyuria. But pyuria can be present even in asymptomatic disease. So wait and see strategies, like we talked about in one of our previous videos, are probably fair as well, especially when the situation is less clear. Enterococcus does not really need, or doesn't really lead to escalation of care. In this cohort, only 2.1% developed complicated disease with Enterococcus, and actually only one patient out of the 339 was in the untreated group. So very, very, very rare. Wait and see seems very fair for Enterococcus. If you've got any sort of ambiguity around symptoms, but if it's clear that symptoms are not present, no treatment is warranted. Really same for anything that grows. We don't treat asymptomatic bacteria except in pregnant patients and right before a urologic procedure. Another interesting thing is that you would expect multi-drug resistant Enterococcus to have worse outcomes. Well, that's not really the case. In this study looking at enterococcal bacteriuria, again mostly device-associated, despite VRE getting consistently missed with initial empiric antibiotic regimens, there was no difference in endpoints, from symptom improvement to all-cause mortality. Normally, with infections, delay in appropriate antibiotics suggest worse outcomes, but it doesn't seem to be the case with Enterococcus in the urine. More data that we need to be skeptical of this bug as a virulent pathogen. Even cooler, even if the Enterococcus is resistant to ampicillin, ampicillin remains a treatment option with pretty good cure rates without notable difference in hard endpoints. Yeah, ampicillin probably concentrates in the urine, but do we really need anything for this infection except for catheter removal? Like, where's the placebo control? I don't know. I would probably treat it if I've got a very clear clinical syndrome, but man, without that, or in ambiguous situations, an Enterococcus can be a tiebreaker to say, I'm not concerned about the urinary tract. I was taught that Enterococcus was a super scary bug that caused a lot of problems in the urine, but the lie detector found that that was a lie. Enterococcus likes hanging out in the urine, but doesn't tend to lead to upper tract disease. Maybe you could just try device removal. Even with resistance, outcomes aren't that different, and using drugs to which the Vitek gives you a big red R might still be an option. Is this different from any other uropathogen? Maybe not. But I hate Enterococcus. Sorry if that makes me a speciesist. It's just annoying. It's like whenever you don't want it to grow, it always grows, and it's always VRE, and it's just like waiting for a curbside. Hey, I got this patient that's better, but now their cultures are growing VRE with a bunch of other crap. What dose of Dapto do you think I need for 4 weeks? I think the important point here is that if your symptoms are at all ambiguous for being attributable to the urinary tract, sole enterococcal growth would make me more skeptical that they actually are not due to UTI. This was the 8th in a series of lectures that you can find at our Viper YouTube channel. Take a listen to our other 9 myths about urinary tract infection that get mistaught in medical school, and let me know if you have questions.